Good morning, good afternoon, good evening to all our participants and to our panel. Today is World Cancer Day, as you would all know, I'm sure. A day that is dedicated to raising global awareness, improving education, and catalyzing personal, collective, and government action to bring about a world where millions of preventable cancer deaths are saved and access to self-saving, life-saving cancer treatment and care is equitable for all, no matter who you are or where you live. The theme of the World Cancer Day is closing the care gap, raising awareness of this equity gap that affects almost everyone in high as well as low and middle income countries and is costing lives. We have over 100 people today tuning into our webinar to hear from our formidable panel of experts why so many people in low and middle income countries are not getting the care they need. Radiotherapy is a cost-effective treatment for some 55% of cancer patients and is less expensive than both chemotherapy and surgery. Yet over 40% of cancer patients in low and middle income countries have no access to radiotherapy treatment, and only 5% of global resources for cancer are spent in these countries. Our panel will tell us what is being done to close the care gap and what more needs to be done. We also want to hear from you. We have medical experts, policymakers, and researchers on the call with us today. Please write your questions in the Q&A function, and I will pose them to the panelists. You'll have an opportunity to ask questions of each of the panelists after their presentations, and you will have more opportunities during the discussion at the end of the panel. For those of you joining on YouTube, please send your questions to info@vcdnp.org. And for our very first speaker, I'm turning the floor over to Dr. Alfredo Polo, who is a radiation oncologist in the Applied Radiation Biology and Radiotherapy section in the Division of Human Health at the IAEA. Dr. Polo is a medical doctor with 30 years of experience in the field of cancer management as a clinician, researcher, program advisor, and a manager. He holds a specialization degree in radiation oncology, a PhD in clinical medicine, and an MSc in health economics. At present, he is responsible for technical support to several programs at the IAEA. He is also managing the research agenda, defining the health economics and geospatial analytical work streams. He is a member of several interagency groups and scientific committees, and he started working at the IAEA in 2011 and joined the staff as a member in 2015. Alfredo, over to you.
Thank you very much, Ingrid. Thank you, VCDNP, for this invitation to the IAEA to participate in this important meeting. I'm trying to share my screen, and please confirm that you see
Yes.
the right screen and that my voice is coming well.
Perfect. Yes.
Thank you, Ingrid. Thank you, Noah, and the rest of the organizing committee for this invitation to the IAEA to participate in this event. We are talking about access to radiotherapy in low and middle income countries, and this is really a very important topic. We know that radiotherapy is an essential component in the management of cancer patients. It has demonstrated population benefit, and therefore it is important to ensure that there is access to radiotherapy for all the population and for all patients that need this treatment. There is an imperative for governments to provide this type of treatment. So we can say that there is a gap in access. There is no enough access to radiotherapy in low and middle income countries. So we can easily calculate this gap if we calculate the number of patients that can be treated with the available machines, and we divide by the number of patients that need radiotherapy. You will find a a coverage figure. And you can say that in high-income countries, more than 90% of the patients have access to radiotherapy. In low and middle-income countries, 50 to 60% of patients have access to radiotherapy. But in low-income countries, only around 10% of patients needing radiotherapy have access to radiotherapy. So there is a problem of access. There is a problem of access to radiotherapy in low and middle income countries. But this message is not complete, is not correct, because we have to link access to radiotherapy to the other components in the cancer care continuum. And it's very important to stress the idea that good cancer policies need to integrate all the components. We are today talking about gaps in access to radiotherapy, but we have to understand that access to good cancer treatment means integration of many different services. And here there is a very, very important and very interesting discussion about what constitutes access, what is access, and how can we measure and define access to radiotherapy in this case. And you see, one of the pioneers in health system research, Varian, defined very well what is access. And the proof of access is the use of the service. It's not enough to have the facilities, to have the equipment, to have the personnel. We have to prove that the population in need is actually using those services. And this is very important. It's not only having the equipment and the resources that defines access, is the use of these resources. Perhaps a more recent definition, more modern definition, see access as the opportunity to have healthcare needs fulfilled. And again, it is connecting the resources with the access to these resources. Very important, and this is a framework that we use at the IAEA when analyzing country programs and country projects. Access is multidimensional, is made of several components, at least 5 components. If you take this framework from Pensansky and Thomas, those are the 5 A's of access: availability, accessibility, affordability, acceptability, and accommodation. So it's not just one element that defines access. There are at least those 5 elements. Availability is exactly this, the fact that we have or not the resources, human resources, equipment, facilities. Accessibility is we put in relationship where is the supply of the services and where are the patients seeking for treatment. Affordability is the relationship between the prices and the ability to pay for these services. Acceptability is putting in relationship the attitudes of providers and patients in need of treatment, and accommodation is how we the relationship between how the supply and the client's needs are put together. So those 5 dimensions define access. Think, for example, about vaccination for COVID. In high-income countries, you have availability of vaccines, you have geographical accessibility to the vaccines, affordability is not an issue, accommodation, you can vaccinate everywhere. But, for example, acceptability, vaccine hesitancy, in many countries or in some countries is creating a problem of access to vaccination. We have everything in place, except that there is an hesitancy to vaccination. So this is to stress the idea that the access to any service is made of different components and different dimensions. And when planning radiotherapy, we have to have in mind all these elements of that define the access. Now, if if we consider the financial commitment that we need to implement, to set up, or to scale up radiotherapy in a given country or region, we have to also have a clear understanding of the relationship between being cost effective and being feasible for implementation. So, for example, one intervention can be cost effective. And when we speak about cost effectiveness, this is compared to some other intervention. So we may have a list of interventions and we may decide, or we may calculate that actually radiotherapy is cost effective compared to some other intervention. So this intervention that might be cost effective, now we have to see if will return the investment that we made. And for this we do the cost benefit analysis, and we calculate if we get value for the money that we invest. So it might be that the intervention is cost effective, and we calculate that this intervention might return the investment. But now this is where the problem starts for many low and middle income countries. Now you have to translate this cost effectiveness and value for money into real cash flows. Now we have to analyze what's the impact of implementing or scaling up radiotherapy on the budget, the limited budget that the government has for implementing many services for many different competing priorities. And we know and we understand that this intervention, in particular radiotherapy, needs high recurrent operational cost that we have to put in this budget impact analysis. And after that, we understand if the intervention will be affordable for the country or not. And we see that in many cases, it is really very difficult to foresee that a given country may sustain long-term the provision of radiotherapy services, because those high recurring operational costs will compete with many other priorities in the country. And very importantly, there is an opportunity cost. If we invest here, we cannot invest there. And for this reason, as I said at the beginning, it's very important to integrate the provision of any cancer-directed therapy into the broad spectrum of the different components in the cancer care continuum. So it's very important to link the financial case, the financial investment needed, with the elements of access that we mentioned before. Now, what the IAEA is doing to help fill in this gap in access to radiotherapy in low and middle income countries. Well, as you know, that the agency was born in 1957, more than 60 years of experience, and it was conceptualized to accelerate and enlarge the contribution of atomic energy and atomic nuclear applications to peace, health, and prosperity throughout the world. The IAEA has several departments, several programs in place that take a very active role from the inception to the implementation and completion of radiotherapy projects worldwide. We have, at the same time, we try to be transparent, disconnecting all the elements of procurement from the technical departments. We have an implementation branch, which is the Technical Cooperation Department and the Technical Cooperation Program, and we have the scientific input to the different programs, which is given by the Department of Nuclear Sciences and Applications and the Division of Human Health. You know, the PAC program, you know, the Human Health program, you know, the interaction of these different programs and departments. And as we discussed before, today, the Director General is also launching in this moment a new initiative, agency-wide initiative called Rays of Hope, that will try to bring together member states, donors, and other partners together with the IAEA to help catalyze investments and to help catalyze initiatives that may help grow radiotherapy together with other cancer services to better define cancer policies and with the ultimate goal of improving cancer outcomes. So in conclusion, my two main messages here today, or three if you want, is the concept of access, which is multidimensional and is made of several components that have to be addressed together in order to fill the gap. The second important message here is the financial commitment and how to optimize and get more value for money, and how to help countries with the impact that this investment had on the budget, and to help countries to deal with those recurrent costs. And third, the new initiative from the IAEA, the Rays of Hope, that hopefully will help again catalyze efforts from different stakeholders and parties, and hopefully will help fill in the gap in access to this important treatment modality. So with this, I thank you, and over to Ingrid. Thank you.
Thank you, Alfredo. And thanks for reminding us that access to services is a multidimensional concept. I have not thought about it like that before. And I also like the quote that access can be measured by the level of use in relation to need. The overview of what the agency is doing is also incredibly helpful. And I think a lot of people on the call today have experienced this support. While everyone is thinking about questions they might have for you at this point, and I just want to remind our viewers that you can put a question into the question and answers or the Q&A function, and I will read them out. But in the meantime, perhaps I can ask you, if we look at the agency is very much moving towards the idea of developing bigger projects which are broader in scope and also highlight the use or the benefits of peaceful uses, and also the agency's unique role in this regard. One of the reasons for doing this as well is to get more funding from non-traditional funding sources. And as you've said, it's really important when we talk about radiotherapy to look at the budget impact and the sustainability in countries. This is an expensive technology. However, of course, if one looks at the benefits that a country gets in the long term, that very much pays for itself, I would say. But in terms of actually being able to sustainably run a radiotherapy center, this is very important that countries have this kind of financial capacity. Do you think that this is in terms of this money that looking for new sources of financing, how would this best help, and how can these sources, it would be channeled through the agency, I would imagine, because the agency has a very unique role. Could you talk more about that a bit?
Yes, thank you, Ingrid, for the question and for those remarks that I think are really important. Maybe I would like to stress the idea that the agency is one stop shop for if you want for implementing these technologies, not only for radiotherapy, for imaging, for nuclear medicine. There is the expertise, and as I said, from the inception of the project until the implementation, completion of the project, there is the expertise in terms of setting up the regulatory infrastructure, setting up the conceptualize the radiotherapy program, setting the milestones, looking for any guidance document for setting up this particular technique or that particular technique, guidance documents for selecting megavoltage therapy, for example, one of the latest publications from the agency. So all the expertise is here, and we try and we help countries from A to Z to set up radiotherapy, nuclear medicine, and radiology programs in their countries. In terms of big projects, yes, there is a tendency now to create big projects because, as I said, we do believe very much in the integration of the different technologies and services. Treatment without imaging for diagnosis means nothing. We are not an agency to implement surgery, but we would like to be able to have everything. And for this reason, we work very much in collaboration with WHO. We try to align also our agendas and to align the way we present projects to the countries. I think this is also very important to point out. And regarding the funding, again, we don't have still in place the mechanism for this raise of hope, but yeah, non-traditional donors are very welcome to contribute to Race of Hope. And yeah, I think what makes this initiative different is that we put in contact in a triangle the donors, the member states, and the IAEA to try to optimize this flow and try to optimize the use of those resources. Yeah, I don't know if this answers your question, but I think you mentioned several very important points here.
Yes, thank you so much. And there's a question from Mesud Belamir from AFCO, and I have managed to somehow lose the question, but let me.
No, it's here.
Is it there? Can you see it? Because I can't see it anymore.
I do see it.
If you could just read it out and then answer it. Sorry, I don't know what I did.
Thanks for the presentation, highlighting the specific management and national coordination management issues challenging largest implementation of radiotherapy in low and middle-income countries, including less developed countries in Africa. Could you develop about the impact missions organized by the IAEA with the WHO and follow-up actions and IAEA continuous assessment of this very important program with the member states? Thank you for this question. Yes, this is, as I mentioned, there are several programs, cross-departmental programs. One of these programs is the Program of Action in Cancer Therapy, and this program is managed by the division of PAC, and there is this important tool, a joint tool with WHO and IARC, which is a full cancer assessment requested by member states. So those assessments are done upon request from member states. We have been in your country, as you know, a couple of times. There is a full assessment, and based on the assessment, a set of recommendations is made. And well, it's up to the country to implement these recommendations. The three agencies can help the countries to do the implementation, and more, we are having follow-up missions, as you say in your question. So we are trying to assess a few years after what was the improvement in the country after the impact mission, and if we can go with the country and help the country to implement some of the activities. Of course, we are driven by the needs of the country, so we react and we try to help also during the follow-up period. Thank you.
Thank you so much. Thank you so much for that, Alfredo. And we'll move on now to Dr. Joel Yarney, the head of the National Radiotherapy, Oncology and Nuclear Medicine Center head of National Radiotherapy, Oncology and Nuclear Medicine at the Center at the Korle Teaching Hospital in Ghana. And Dr. Yarney is a consultant oncologist and director of the National Center for Radiotherapy, Oncology and Nuclear Medicine at the Korle Teaching Hospital. Sorry about that. He's currently involved in clinical work, teaching and research, and has been a faculty member of the Ghana College of Physicians and Surgeons since 2004. He chaired the committee that authored the cancer control strategy for Ghana and oversaw the implementation of a program to upgrade radiotherapy and nuclear medicine services in Ghana. He's currently the project scientific consultant for the IAEA with respect to the training of clinical radiation oncologists in Africa. Thank you so much for joining us, Joel, and it will be really good to hear from a country perspective. I hand the floor over to you.
Right. Thank you very much for the opportunity to share my experience regarding radiotherapy in African countries in particular. The need for radiation therapy is born out of the need to treat cancer well. Of course, cancer has been with us for a very long time, but predictions from the World Health Organization and also from registries across our countries predict that because of several reasons, including increasing life expectancy and adoption of certain lifestyles, including alcohol intake, smoking, and control of childhood diseases, the life expectancy of most African countries is likely to increase. Indeed, in Ghana 20 years ago, the life expectancy was on the order of about 57, but currently life expectancy at birth is 64 for men and 67 for women. And with the increasing life expectancy, the chances of developing cancer is going to increase. And with the increasing incidence of cancer, it means that we have to brace ourselves to treat the disease well. Unlike previously, that the burden of the disease was low. So because of the increasing incidence, as shown by the figure, this increase is steeper. It's much steeper for less developed countries. Look at the gradient of the graphs. It's evident that the rate of rise is much steeper than for more developed countries. So we have to develop facilities to manage cancer well in African countries. Development index versus cancer incidence. The blue representing incidence and the red representing mortality. So, point made earlier on, the burden of cancer is much higher in countries with high development index. but a critical look at the charts show a wide variation between the blue and the red for a specific diagnosis, for instance, breast or high HDI countries, compared to low HDI countries like Africa. The difference between the red and the blue is not much, which means that countries with high development index can influence survival. Gap is wider. They are doing something about cases and are treating them so they are surviving longer, compared to the blue and the red for low and medium HDI, where if you develop cancer, it means the chances that you're going to die from it. So the message from this bar chart is that something can be done about cancer. The least we can do is to implement a strategy that will help us to bridge the gap between incidence and mortality, as has been done in high HDI countries. So in Ghana, take this from WHO global figures. So in terms of ranking of cancers, breast cancer is #1, followed by liver, cervical cancer, prostate cancer. These cancers require use of radiation therapy for management. Radiotherapy plays a critical role in the management of breast cancer, management of cervical cancer, and prostate cancer, amongst the others. So, and this picture is similar to a lot of developing countries. For cervical cancer, for instance, we know the relations with HPV and then lack of screening by all kinds of methods. There isn't a countrywide program for screening. And even immunization is lacking. The penetration is low. And even if there's wide adoption of vaccination against HPV, we know that there's a latent period between inoculation and development of cancer. So for let's say 20 to 30 years, the incidence is not likely to change because those who have been inoculated with the virus already will have a high chance of developing cancer. So for countries with low HDI, radiation therapy is critical in the management of cancer because of the spectrum of diseases that we see. For management of cancer, as we all know, we need surgery, radiation therapy. And the contribution of radiation therapy, according to a Swedish trial, is substantial. Of all patients that have been cured from cancer, radiation therapy accounts for between 35 and 40% of all cures. Again, it is important for palliation. Indeed, in our part of the world, the proportion between patients coming with locally advanced disease versus those coming with early disease tilts in favor of the advanced disease. In other words, most patients will, or I shouldn't say most, let's say about half of the patients will require palliation because at the time of presentation, the extent of the disease is such that it cannot be cured. So radiation therapy is required for good cure palliation, but in developing countries, for palliation, radiation therapy plays a very big role. So the benefit of radiation therapy cannot be overemphasized. Having said that, if you look at this map, most African countries have very low level of number of megavoltage machines. This is from the IAEA, number of radiotherapy machines per million people. 2017. It has improved a little since then, but in general, Ghana, for instance, we have 1 to 3 million sharing one machine compared to the rest of the world, where less than 500 people will share a machine. So there's the need to, even though the incidence of cancer is not so big in Africa, there's the need to increase the number of machines so that we can treat patients either with curative intent or with palliative. Ghana participated in a multinational trial assessing actual utilization of radiation therapy and optimal radiation therapy utilization. This was published in the Green Journal. And if you look, the second on the list is Ghana. Optimal radiation therapy utilization is of the order of 51%, but the actual utilization is 9%. So there's a wide gap between what should be offered to cancer patients and what is actually happening. So we can say that we have radiation therapy in the country, which is available, but use is not optimal. And the high value of 51% is attributable to the distribution of cancers within the country, as explained previously. We have not gone further after this study to establish why utilization is low, but there have been anecdotes to that, which I will discuss shortly. So there are several reasons for delay and utilization. So it's important to have the service within the country, but in addition to that, there has to be a holistic approach for it to be effective. For instance, access delay, for cancer awareness, people may have symptoms but not present. Even delay in diagnosis. What interpretation does the doctor give to, for instance, a patient presenting with bleeding perirectum, which will be taken as, let's say, hemorrhoids, even though it's probably due to rectal cancer. And then after, when the diagnosis is made, how soon does the patient get to the couch of the radiation therapy machine? So there are several delays that lead to late presentation, and there are barriers to treatment, including financial barriers, logistical barriers, and psychosocial barriers such as paradigm to disease causation, which influences presentation. So the management of cancer, the use of radiotherapy should be linked to the total management of cancer. Otherwise, you even buy the machines and the use will be poor. So late presentation, I've discussed some of these factors already, may lead to low utilization of services available and the benefits which you can derive from the presence of radiation therapy in the country. Ghana, even though ratified peaceful use of atomic energy and became a member of the International Atomic Energy Agency as early as 1958, it took a long time for us to have radiation therapy services. Indeed, the first patient to be treated in Ghana was in 1997, so quite late the scheme of things. And we established the first radiotherapy center, very simple one, and we did that with the help of the agency. So the role of the agency in establishing radiation therapy centers cannot be minimized. They play a very crucial role in ensuring that you have the establishment of radiation therapy, working with governments and also to ensure that you have adequate staff and also the safety. So this sort of summarizes installed capacity as of now. And to draw your attention to one of the reasons why radiation therapy utilization is poor, look at what we've labeled as figure 1. So there's a mega voltage machine in the mid-zone, Kumasi, and then 2 in Accra, shown as the red stars. So it's pretty obvious that the rest of the country, in fact, more than half of the country, the northern part, does not have any radiation therapy machine. And this will definitely influence utilization, apart from the other barriers, financial and so on. We started off with a cobalt machine in 1997 and changed it once. So there's a new machine. It's not the one that we started with. Now we have a machine from Best Electronics, and then we have linear accelerator, 1 each. It's a private center that has 1, and then the government 1. Because we do low dose rate brachytherapy, permanent implants, so then we have high dose rate therapy as well. But mainly the message of this slide is the distribution of the machines, which leaves a lot to be desired. So we have to improve the distribution as a first step for us in order to improve utilization. And reliably, in fact, I have a meeting at 4 o'clock in which we are going to discuss that. The government is buying about 5 linear accelerators to improve the distribution, and there will be 1 located up north and another 1 somewhere in the middle, another 1 towards the western part of the country. So that will improve utilization. So what the message here is that you must not view radiation therapy in isolation. It must be part of the broad context of cancer control mechanism, which you work at. Otherwise, you may have the machines, but all the barriers to care must be addressed. And if you have a guideline for cancer management, then you would have radiation therapy there in the document, and that will provide a guide in terms of care and referral patterns. Because one of the things that we've noticed is that not all doctors are aware of what radiation therapy can do. So if it is in the guideline, it helps in decision making, even in the periphery, and to guide referral to appropriate centers. Now, from the brief that I had, it appeared that there's interest in our use of cobalt. We use linear accelerator as well. So I've taken the liberty to try to compare the two to see how well the two can address the barriers. So there's the initial costs. Of course, the linear accelerator is much more expensive machine. So the financial access, even in practice, the costing is different. Sometimes it may become a human rights issue, but those are the realities of the ground. My personal experience, even before the LMIC, we were using the cobalt, and we have cured a lot of patients with that. Even in patients with high HDI, I'm sure they were using cobalt previously, and some of the patients did. So initial cost is higher. Maintenance cost is much higher for the linear accelerator. But then the other side of the story is that you don't have to do a source change linear accelerator, and you have to do a source change about every 6-7 years. Also, that's a downside. So, and that source change is also not cheap, so that will feed into the cost. Radiation protection issues, safety and security issues. The linear accelerator may have a slight edge in terms of that. But most importantly, the linear accelerator, I'm sure, will be demonstrated by some of our panelists later. And there's flexibility in planning. We have access to IMRT, which we do, and therefore therapeutic ratio, which will be the ratio of efficacy versus toxicity, is higher for the linear accelerator compared to the cobalt. And therefore, you find that most of our patients will be treated on a linear accelerator. Probably the palliative ones, that is our practice. We go to cobalt, even though occasionally we have some curative patients who cannot afford. That's a human rights issue which we cannot discuss today. In general, from our figures, the cost of treatment ratio may be of the order of 3 to 1. So when costs and maintaining treatment is a barrier, cobalt is probably considered. So having the two is helpful, at least for us. This is our point of view as of now. And to sustain the system, these are the logos of the training institutions that we have. It's not, you shouldn't consider equipment in isolation. In addition to equipment, you must have facilities for training. Otherwise, they'll become white elephants, or you treat, but you would have toxicity, a lot of toxicity. There wouldn't be full use and appreciation of the use of the machine. Of course, you must have a national regulatory authority. That is the first that you must have for low and middle income countries in order to show safety, make sure that the public is not harmed. Then we have a postgraduate, Ghana has a postgraduate training for oncologists, for oncology nurses, for medical physicists, and also for radiation therapy technologists. This must work in concert to make sure that you have the full force human resource capability to manage cancer for good outcomes. If you concentrate too much on the equipment and desert training, then your outcomes will not be optimal. So my message here is that the countries must consider radiation therapy in the full context of a cancer control program. They must look at issues of cost. They must look at issues of geographic distribution to ensure country-wide availability, and also training is very important to optimize outcomes. Thank you very much.
Thank you so much, Joel. It is really such a valuable insight into the challenges that you are experiencing in terms of improving distribution or access as such. And again, making that message clear that radiotherapy cannot be looked at separately from the entire cancer care program. We have a question here from Edward Gerskevich that, well, he's saying the cost for basic LINAC is more or less similar than cobalt 60. It is features that LINAC has MLC, EPID, KV, imaging, etc., which makes it look more expensive than cobalt 60. If you add all this functionality to cobalt 60 unit, it will then be on a similar scale. What is more expensive is the maintenance and therefore the whole life cycle of equipment acquisition, maintenance, decommissioning, and need to be considered. We're going to hear more about linear accelerators, I think, later on in our discussion. Joel, is there at this point anything you'd want to say in response to this? And I just want to also note the fact that you are using both cobalt 60 and linear accelerators would you say that actually improves the ability for the cancer care in the country, because it responds to different needs and different realities in the country? Or
It does.
yeah.
It does very, very, very much. Because I mean, I'm agreeing with him. It's the initial touches and the level of sophistication. I mean, of course, the cobalt has one energy, whereas the linear splitter, you can have several energy. So there's flexibility in planning, and therefore improve your therapy. There are issues of the commission.
Sorry, Joel, you're actually coming in and out when you speak. So if you can just lean forward and speak towards then we can hear more clearly. Sorry.
Right. Thank you. I'm agreeing with the statement made by the participant that there are several issues to be considered, most of which I have listed. But from actual figures, we realize that the cost ratio is about 1 to 3. And so patients who are treated on the cobalt who do not are endowed enough to afford the linear accelerator have improved access, because but at some point it becomes a human rights issue, and determining who to treat here, who to treat that, it's not an easy decision to make. But that's our reality. That's our reality. I know of countries that have started nicely with only linear accelerators and have not maintained it. And after about 10 years after initial start, and they appear to have a very good program, they just decline. And you have moments when there's even no functional machine. So starting is one issue, but keeping the program ongoing, making sure that on time is high, and therefore treating your citizens is something to consider. And that is where the health economics comes in. And that is where we think that the cobalt has helped us, at least up to now. That is a reality. Thank you.
Thank you, Joel. So there, I hear you talking about the issue of sustainability then, and as echoing what Alfredo has said at the beginning. So now we'll go to our next speaker, who is Hester Berger. She's the Medical Affairs Project Manager at Varian in South Africa. Hester is a medical physicist with a passion for improving quality of cancer care through education. She is currently employed by Varian Medical Affairs to assist with the management and creation of practical radiotherapy training courses for teams who are implementing modern radiotherapy techniques for the first time. One of the key education programs she's involved with is Access to Care Cape Town program that focuses on delivering practical radiotherapy training in the region. She was previously employed as the Director of Medical Physics Division at Groote Schuur Hospital and the University of Cape Town. Hester, over to you.
Thank you very much. Can I confirm, can you guys hear me and see the screen well?
Perfect.
Thank you very much. Firstly, thank you for the invitation to do this presentation today. It's World Cancer Day. It's a very special day for all of us involved in cancer care, because it reminds us, as you said, that cancer is supposed to be something that every patient that has it should have access to care. And I was asked today to look at it slightly different from the previous talks, but from the point of the role of education in the transitioning to the modern techniques. So this is what my talk is about. Just the quick disclaimers, as Ingrid just said, I do work for Varian Medical Affairs now since the start of this year. But the project I'm talking about, the Access to Care Cape Town training project, is a collaboration between the University of Cape Town, Cape Peninsula University of Technology, and Varian Medical Affairs. But we also make use of additional resources, training collaborators, Radicare Humanitas, and Planning for Africa. So I just want to put it, this is a big program with a lot of people helping. I'm just presenting it. I know there are people on the call that are not necessarily technical. So I thought one way of explaining the risks of moving forward with modern radiotherapy is a bit of a case study. The case I've got on the screen is a gynae patient. And if you look at the top row, this is a typical plan that would be generated on something like a cobalt unit or a linear accelerator if you're using simple ant and post fields. The fields that I've got on there were marked on bony anatomy. In other words, not necessarily a lot of CT work, contouring, etc. The margins are wider, and this is very typically how a patient would have been treated on a cobalt for a very long time in many centers. Then the next line, we move a little further. We look at 3D conformal radiotherapy. This is where we can start shaping for every field. We have MLCs in this case, and you can start to see how we have the ability to bring the hot dose, the target dose, more and more onto the target. And green is the lower dose areas that is starting to protect the normal tissue more and more. So that is 3D conformal radiotherapy. And then the third line that I've got there is an example of an inverse planning technique. In this case, with volumetric modulated arc therapy. This is, in many places, is considered now state of the art, the way to go. This is what departments dream of implementing. And you can see clearly how we're able to really shape the hot dose, the bowel in this case. I always tell the people, this is Mickey Mouse. You can see how you can shape it, get high dose to the. The question that I have to people attempting this is this: what is the ideal world that you see on your planning system, and what is the reality of what you're doing in the department? I don't know about you, but I think all of us have watched MasterChef or Cake King or anything like that, and then you go into your kitchen and you bake it yourself. And the people always tell me to stick to physics and go away from baking, because if this is my result, they don't want me near them. But what I'm trying to show is this: our 3D conformal field, it has some shaping. On my planning system, in the ideal world, I'm hitting my target very effectively. In my kitchen, even if I don't bake that well and I have wide margins and I place them with bad setup, I'm missing a little bit of my target over here, but I'm still hitting the majority. But when you start moving to the more and more advanced techniques, take a look over here. Remember the Mickey Mouse from the previous plan? I'm now only shaping to the face. This is where my true tumor is. I want to spare everything around it. But now things go wrong when I execute on this. My baking in my kitchen is not what my planning system is showing. Then this is what I'm delivering. So with an increased complexity, the more complex techniques, there's an increased need for accuracy in terms of dose, accuracy in terms of delivery, our positioning, accuracy in terms of the quality assurance to make sure the machines are doing what they think they are doing. And as a result of that, there's this increased need in training. So I've taken the same example I had on the previous screen, and this is called a dose volume histogram. And all it shows, for those who are not so technical, for my target, it shows I've got good coverage. In a really ideal world, it has the shoulder shape, and then it falls down, so no excess dose, but my entire target is covered. And this one with a good shape is my VMAT case. I can clearly see the advantage. This one at the bottom with a yellow arrow is my 2D case. I can see I'm missing a little bit because I did marking based on bony anatomy, but it's actually not a bad plan in terms of the tumor. I know I've got higher dose on my critical structures, but let's just take a look at what happens if something goes wrong in execution. This is an example, exactly the same case. I've introduced an error in positioning of 8 millimeters. 8 millimeters, less than a centimeter. This is the kind of thing that can happen very, very easily in a department in body work where you are not perfectly accurate in your setup. On my 2D plan, because of my wide margins, both my original plan as well as my bad setup give approximately the same results in terms of my tumor because I started off with a wide plan. There was a space for movement. But my VMAT plan, on the other hand, remember my ideal master chef kind of curve over here, a shift of only 8 millimeters causes the tumor dose to drop. Here, the dose that I actually wanted on my target, about 20% of my tumor is no longer getting sufficient dose to control the cancer. And this ideal plan that I wanted to give to my patient will most likely result in a tumor regrowing, a recurrence, and even though I saved my critical structures, the reality is that I may not have done my patient a favor. The only way to come over this or get past this is actually to train people to do this effectively. The problem with training, or one of the problems with training as I see it, is this. We know we have a fast-changing technological field. If you look at the images on screen, the graph that I've got in the middle, it shows what is published as the timeline for prostate, the type of radiotherapy that is done. Yeah, in the 50s and the 60s, we went from cobalt to LINAC, started shaping the fields, moved to 3D. By the year 2000, according to the timeline and the high-income countries, people were implementing IMRT. Let's take a look at the reality of a place like Africa as an example of a low and middle income countries. The study showed the assessments of 1998, so the closest I could find matching to 2000. There were only 155 RT units, 60% cobalt, the majority of them doing 2D palliation. Africa now in 2020 is seeing a growth in machines. A lot of the machines are less than 5 years old. They have the new capabilities, but the problem is the rest of the world is confident with these techniques. We want to jump in and do it immediately, and we forget that we also have to do the training, the principles that goes with the 2D world, with the 3D world, all the way to the IMRT, in order to implement it safely and ensure that what you are delivering, what your patient is getting in terms of dose, is what you think you are doing. Now, in 2014, we realized that there was a gap, or a problem with the synchronization of the training programs between the high-income countries and the low and middle-income countries, and formed a collaboration, as we said before, between the two universities and Varian. And the aim was to go very simple. It's little short courses that focuses on practical skills for already qualified radiotherapy professionals who want to move to more advanced techniques. It's not in competition with the university programs, the formal education. It is aiming to fill those gaps. And we made sure that we followed a stepwise approach to these training programs. We don't want to jump into the high-income country world expectation. We want to step back and say, if you want to do this, you must first learn the basic modern radiotherapy principles. So the first of the courses is the 3D conformal, but it is actually way more than that. It is 17 contact days spread over 4 months. It includes pre-course online learning, but very important, it teaches the teams to look at departmental design, procurement, radiation shielding, staffing. What do you need to execute on this? What do you need in terms of imaging, contouring, planning? So you take your ICRU principles, you teach them anatomy on CT and MRI, and that is how you go forward. Now, once the team has completed that or reached the levels of that, we move them a step further, intermediate to advanced. We've got 2 courses who join forces here. So it's Introduction to Advanced Techniques. It's like a first glimpse at these techniques. And then we go a little bit deeper for another 6 days to look at VMAT, SIB, slightly more complex cases. And then the last category is what we call targeted training. We have 2 top-to-toe courses there. Top to toe, literally meaning from the head, systematically going and anatomically down with cases. And here we only teach technical planning skills, how to get the pretty pictures on your planning computer, but also how to QA them, how to make sure that they are correct. And then a new course this year that looks at stereotactic radiotherapy, the kind of cases we see in LMIC, not SRS, and then pediatric radiotherapy for low and middle income countries. Now, of course, COVID changed everything for everyone. Previously, the teams came to us in Cape Town, but in 2020, we converted the entire program to remote teaching. I found out soon enough that you have to keep them engaged. If you're going to spend 6 hours a day with people online, you have to use different teaching methods. Some of it is front-facing, some of it is recordings. We have a VERT system available to us. That's like a flight simulator for Linux. We can record error sequences, show them fault scenarios. We're very, very lucky in that we have a laboratory of Eclipse computers. This allows us for students in their own departments to go on a web page and they can access our training database, and we can duplicate their screens so that we can see what they're doing while they're doing it. So over here, you can see I'm currently teaching. There's my one group sitting somewhere in Africa, another group, and there is my laptop with Zoom. I've got a headset on and I'm talking to my teams while they are contouring, while they are planning, so that we can help them live while they are working and take them through these steps. We became creative with video recordings, live streamings. We found a 100-meter network cable can get straight into a bunker. There's no reason why you can't stream from the inside of the bunker. And then we do follow-up mentorship with them on Outlook and Zoom. So actually, in many ways, I think COVID did us a favor in terms of reach, because now our only limitation is time zone. And this map gives you a little bit of idea of the teams that have attended from 2015 to 2021. You will actually see Ghana there. Dr. Yarney's teams have visited us, both Accra as well as Kumasi. And the size of the circle just gives you an idea of the number of teams from the countries that have attended courses. This year, we're also including the United Arab Emirates and a second team from Pakistan. So the program is reaching out further and further, and we are very proud of the work that has been done so far. The good news is it's not just us. This is a worldwide effort. This is just a couple of things that are screen wrapped of programs available to people who are interested in filling their own knowledge gaps, whether it is eContour, whether it is the IAEA's training material, the ECHO projects. You can see articles in there. The partnerships are there. People can reach out, they can find the information. The fact is that the world has joined forces, and I believe they are improving the education that is available to people who want to transition. So thank you very much.
Thank you so much, Hester. That's just, it's brilliant. I think halfway through when you were talking about and showing exactly the difference in gap between being able to apply this 3D technology in effectively, and then what happens if you don't. I became a bit overwhelmed and thought, oh my goodness, the problem is really huge. And then, of course, with this training, it's fantastic. And it's so encouraging to hear as well that you were able to do this online. Because what we've often heard, and we've heard that from some voices within, of course, I'm South African as well, and I'm often thinking, how can one do this in countries where there's often not good internet access? So if I can ask you just quickly before I and abuse my position as chair, how do you deal with this? Do you find that this is relatively unproblematic?
There are countries where we face internet connectivity issues. That is true. Many of the teams that we've been working with, where their original internet connectivity failed, they actually went out and they inquired in their own areas and regions, and they found alternative connection options. So sometimes their hospital connections are not the best option available to them, but they can find an alternative service provider and they go onto the internet for that. So internet is the one thing that we absolutely need in order to work with them. Some of the material on the online training platforms we can upload for them, which means that it is easier. So some of the video material they can access in their own time. Often they find the bandwidth is better after hours. Our bandwidth is the worst on a Friday afternoon. I do not know why. Maybe everyone is downloading their Netflix movies. But internet is one of the key constraints that we do face teaching that way. But I have to say that the majority of the teams have found ways to get past it. And our philosophy is this. Say we work with a team and they actually end up losing 10% of the total contact time. We still had 90% contact time. That is a lot. And for those teams, we then set up special sessions at a later time, one-on-one. We re-engage with them and say, okay, can we repeat what we did? Because obviously you guys dropped off, let us refresh it. I'm going to give you access to the database for longer so that you can practice again. So that is how we've been dealing with it up to now.
Fantastic. Thank you so much. I have a question here for you from Mesut Balomir, the Executive Secretary of AFCON. He thanks you for your detailed presentation and raising the huge and sensitive issue of technology development in radiotherapy and medical physics, and the required quality in education training, in particular clinical training, not always available in Africa, as we've just discussed. He asks whether you could talk some more about the current situation in Africa in terms of medical physicists available and the gaps, and B, how to mitigate this unavoidable consideration by the LMIC countries of the up-to-date technology for new radiotherapy centers with the challenges related to qualified human resources.
Thank you for the question. So the medical physics programs, I think there is a rise in awareness if you look at organizations such as FAMPO, the Federation of Medical Physicists of Africa. There's a rise of awareness of working together to address the medical physics shortage and to make people aware of the role of the medical physicist in this fast-changing technology. One of the main things we have to get people to understand is that the initial procurement is where already you want your medical physicist involved. You need someone trained to understand the integration of the systems, the implications of the equipment that has been selected by the people with power, the people with money. So there are programs starting up. There's I think it's called the Global University, that they've started to try and create online training programs to give more medical physicists access. The IAEA is instrumental in facilitating fellowships for people who have base degrees to do fellowships at established universities, such as University of Cape Town, for example. We've hosted several fellows over here. So I think the main thing is awareness, the fact that you understand there's a need, and you start building capacity with a medical physicist. But it's not just them. The same goes for the RTTs. Their role is so different when you move to the modern technologies. In fact, our philosophy is we never ever teach. We teach teams, we never teach individuals, and the teams have to have a radiation oncologist, a medical physicist, and an RTT in the same team so that they can actually talk to each other. And by talking to each other, they start to learn the worlds that the other is living in and the risks and why people are saying certain things. Because it's through understanding each other that we start to improve the overall service.
Yeah, that's a great answer. I think one of the questions that we always get and that we're also concerned about in terms of the use of LINACs in developing countries and least developed countries in terms of, and you've addressed that very well in terms of capacity, is that we have the providers or the providers of the LINACs who bring this technology into countries and it's bought by countries, but then there's just not the capacity that goes with it. But it's very, very heartening to hear all of this work that Varian is doing, and I'm sure this is also being done by the other provider. But what I wanted to ask you, and we got a question online on this one, is what is the cost of this training, and how does this, is this part of a service that Varian delivers to countries that are using LINACs or its LINACs, or how does that work?
It's originally, when the training was set up, it was set up in such a way that when equipment was procured, Varian would build this into part of the purchase so that the people would automatically get access to it. But there are other partners involved as well. The Global Access to Cancer Care Foundation has sponsored several teams to travel to Cape Town prior to the pandemic, and then they would cover all the costs of attending. We hosted 2 teams from the IAEA that were sponsored through the IAEA to attend the training courses. So there are multiple avenues of getting into the training. At present, the training and now during the pandemic has been sponsored by Varian Medical Affairs because the lowering of cost as a result of it going online and because of the uncertainty surrounding it. For this year, the teams that are attending are allocated spaces based on need, and we try to accommodate as many people as we can, and then they will go back to the procurement model as I understand it. But if people are interested, and even if they do not have the funding, they can contact the Global Access to Cancer Care Foundation and apply to fund, to be funded by them for access to the courses. So there are multiple avenues into the training for it.
Thank you so much. We have one more question from Peter Kisembo, who says, how can students who have completed a course in medical physics from other African countries access this training? I think you just answered that by saying one can apply to global access.
Well, if they need funding, they can apply to Global Access to Cancer Care. If they simply want to ask the question, they can speak to any of the Varian representatives in their regions, and they forward those requests to us, and then we create priority lists. Needless to say, we're almost running on a waiting list at the moment. The 2021 courses are full. We're already getting teams for 2022 because we can only take 4 teams on a course because it is 12 people, 4 teams. All of it is interactive. So it's limited, but it's ongoing. So since 2015, you can see the reach is expanding quite fast, and it's baby steps. For me, one of the quotes I love the most is from Maya Angelou, and she said, do the best you can until you know better. And when you know better, do better. And this is what we're trying to tell the teams. Do not be shy where you come from. All we ask you is work with us, work better every single step of the way. We're going to walk it with you.
Thank you so much, Hester. That's very inspirational. I'm going to turn now to Eugenia Wendling, or Nina. Nina has dedicated nearly 35 years to public service, the last 20 years working within the cancer community. She has served as the Executive Director of the International Cancer Experts Corps, the ICEC, since May 2015. And in this role, she provides oversight to achieve the ICEC's vision. She also directs the ICEC's efforts regarding Project Stella, which is a public-private partnership which develops innovative healthcare technology with the European Organization for Nuclear Research, CERN, in Geneva, and the UK Science and Technology and Facilities Council, as well as the UK universities, and directs ICEC's network-oriented global partnerships that emphasizes sustainability and growth through the ICEC's twinning programs. Nina, please take the floor.
Hi, Ingrid. Hello, everyone. Thank you for that introduction, and thank you very much for inviting ICEC to present at this important webinar and discussion. So my name is Nina Wendling. I'm with ICEC. We're a nonprofit based in Washington, D.C. Give me a moment here. Sorry, I'm having a little problem with my screen. Okay, there we go. For my outline of my presentation, I'm going to provide an overview of ICEC and our system's approach to care. I'll define the needs and gaps in cancer care, describe efforts to increase access to suitable, affordable, and sustainable technologies. And I'll comment on how cancer care is an integral part of a healthcare system, a concept that we call flex competence. And then I'll also highlight the impact of global oncology. So ICEC is a recognized 501(c) nonprofit based in the United States. And our mission is to reduce mortality and improve the quality of life for people with cancer and LMICs. In addition to this, we also address the needs of indigenous and geographically underserved populations in upper income countries in regions worldwide. And by this, I mean our Native American populations, First Nations populations in Canada, the Maoris in Australia and whatnot, and New Zealand. So ICEC accomplishes this through a global mentoring network of cancer professionals who work with local and regional in-country groups to develop and sustain better cancer care. And this is really where improving access occurs. if we can support knowledge and training to use currently available and evolving technologies, we increase access to radiation therapy. So many of you know these statistics, so I'll just go over them briefly, but I'll highlight some important notes here. We have a growing global cancer crisis. And in 2018, 18 million new cancer cases per year were diagnosed with 9.6 million cancer deaths. By 2040, the numbers are going to be projected to 27 million new diagnoses and 16.3 million deaths. And of these deaths, 70% of these will occur in LMICs. And I think Joel and Alfredo commented on the complete spectrum of care is needed. It's not just radiation therapy we're talking about, but rather it's everything from prevention, screening, diagnosis, treatment, and long-term follow-up. And this really is critical. And with more than 50% of all cancers can benefit from RT for cure or palliation, we really need to look at the solution to bring RT, and that solution requires expertise in enabling technology. So here's a map. We've seen another map earlier in these presentations, but access to radiation therapy, particularly in LMICs, is really an excellent metric of the gap in comprehensive cancer care. You'll see on the right, the map of Africa. The red countries have no access to radiation therapy. This is a map that was pulled together by IAEA in 2020. So the numbers are relatively accurate with some changes. But the disparity in access is really remarkable. In Ethiopia, at the time we did this, they had one operating LINAC, which means that there's one LINAC per 115 million people. Nigeria begins to improve at 7 LINACs, one for 29 million people. And then the disparity is reflected in these upper income countries, especially with the UK and the US and Switzerland. The US has 3,827 LINACs. That means one LINAC per 85,000 people. So Africa, with 29 countries that have LINAC RT facilities, 12 of those countries only have one, and there are 27 with no LINACs for RT. And so this is a significant issue that we all need to address. So with access to radiation therapy, we really have to look at what's our radiation oncology workforce projections. So this is a terrific little article written by Shakina Elmore, Ben Prajogi, and Alfred Polo and Zubra Zareta of the IAEA, excuse me, that showed that the current numbers of practicing radiation oncologists in LMICs in 2018 were 664. But their projections for 2030 is that the need is 13,322 radiation oncologists will be needed. Of course, that's assuming there's adequate investment in radiation therapy infrastructure to support them. So what we look at is, or what the article looked at, was the challenges around training the number of future radiation oncologists that will be needed. There's a lack of qualified teaching faculty. The demand also exists in high-income countries. There are remarkable cost considerations. We still have a brain drain issue, something that we need to slow and actually reverse in some ways. But these numbers, as daunting as they are, also don't represent the shortages for all other radiation therapy personnel, like medical physicists, like as we were just talking, dosimetrists, technicians, and oncology nurses. So IAEA's approach to this is really two tracks. So the first track, and really the mission of IAEA, is to increase the workforce capability and capacity. As you can see on the right, this is what we call our expertise. That's what IAEA really brings to the table. It's a global mentoring network to build capacity and training. And we do this through IAEA twinning programs, where we leverage relationships that we have or that we can develop with academic medical institutions in high-income countries, private practices, professional societies, and others. And we partner with cancer hospitals and individuals in LMICs for knowledge and skills transfer. And the second track we have is understanding the technology gaps to increase access to radiation therapy. We do this by developing and leveraging our trusted partnerships. We're involved in research and development. We work to understand the enabling technology for treatment and knowledge transfer. And then we implement the lessons learned from this work in various projects and studies. So in understanding the technology gaps to increase access to radiation therapy, ICEC leverages our trusted partnerships to identify these gaps and really to develop the solutions to increase access to medical LMICs for challenging environments. We do this by gathering information. We've done significant surveys of hospitals, facilities, and healthcare providers regarding the challenges faced in providing radiotherapy in Africa. And I have highlighted that from and encourage you to read an article with the lead author of Taufik Ige, a medical physicist from Nigeria, and it's surveying the challenges to improve linear accelerator-based radiation therapy in Africa. Through this and other research, we identify the challenges working with those on the ground who work with these machines day to day. But through all of this, we must keep in mind that it's not the machines that treat patients, the people do. And without a workforce that has the capacity and capability to do this, the linear accelerators can't be used. So we educate, we mentor, we sustain tech expertise through exponential growth, using metrics to assess our impact and to guide future growth. So our outreach and engagement efforts, as I mentioned before, we leverage and expand relationships to increase access. And we do this with partnerships and relationships with IAEA, with their human health and May Wahab, PACT and Masood and Lisa Stevens. We do this through CERN, working on our research. We work with the US DOE, the NNSA Office of Radiological Security on looking at alternative technologies and trying to help transition to those from cobalt machines. Our research and surveys understand the barriers to access radiation therapy. As I mentioned, the African survey with the LINACs, CIST, which is a survey that ICEC individuals were leaders in. That's the Southeast European states. And we have an ongoing Eastern Europe survey to understand the challenges there with access to oncology and research opportunities. We work with professional societies like the American Brachytherapy Society, ESTRO, Medical Physics for World Benefit, and international organizations and NGOs like the Vienna Center, WHO, UICC, the UN in Congo, WINS, Wilton Park. So we look at ICEC's healthcare solution. We really believe our solution is a global network, and we work to build and strengthen workforce capacity and capability, enabling a response to crisis through expanding a flexible network of expertise and resources. And this looks like a complex figure, but really you can see the regional clusters here that leveraging the mentee-mentor relationship, trainings, satellite and remote clinics, directly connected through our global expertise network to committed healthcare organizations that offer expertise for mentoring and options for smart technology. And we work with our industry partners and government agencies and others to try and strengthen the global supply lines that have surge capacity, which we found have been very valuable, especially during this pandemic. And lastly, I'd like to just take a look at this image, this one last figure. This was from a broad impact for global oncology, an article that we submitted, ICEC submitted as a viewpoint to the JAMA Oncology. And I just want to note, with the attention that global oncology demands, it provides really an extraordinary opportunity to address the need for cancer care while serving as a catalyst for solutions that address many societal needs. So radiation therapy is really embedded deeply within the components that make up patient-centered global oncology, the center circle here of this diagram. And these include technology, funding and support, expertise, treatment, research development, etc. And I mention that because the benefits that society gains, which are here in these green ovals, from these components include encouraging relationships and partnerships, also encouraging public-private partnerships to solve some of these issues. It encourages healthcare delivery innovation, novel partnerships to advance goals. It captures wisdom from senior or retiring experts. In our twinning and mentoring programs, we have many senior and retiring experts that are brought out of their practices at 65, but they have all a wealth of information that they're willing to share. Academic and private sector global health career paths, comprehensive cancer care that includes infectious disease and non-communicable diseases, accelerated research implementation, disruptive innovation, reverse innovation, which we've found has been very interesting to see how many times we learn things from people that we're working with on the ground, and catalytic innovation to address intractable problems. So in summary, increasing access to radiation therapy will have a broad impact for global oncology and for society, encouraging partnership, investment, creativity, innovation, altruism, and societal collaboration. And for that, I thank you. This is a series of resources that I mentioned throughout the talk that you can we can make available to you all. And lastly, just thank you. And these are some of the partnerships that we've been working with and on. And I encourage you to come to our website to learn more.
Thank you so much, Nina. I really like this idea of the patient-centered global oncology. And exactly, I think what we've displayed here in the discussions we've had so far is how important this network is of partnerships and to improve training and to improve delivery of technology that is usable, and also that we use all of the expertise that we have globally, because we don't need to feel, because we don't have it in a country, that we don't have anything, because we actually have so much to draw on. And I think this brings us to the broader discussion I'd like us to have. So if we let's take radiotherapy now and look at just improving access and the discussions, the questions we've had in terms of, we've got the linear accelerators and we've got cobalt-60, if we simplify it. And the reason, one of the big benefits, of course, apart from Linux, apart from the fact that they deliver more precision care at the moment than cobalt-60 teletherapy does, is that Linux have none of the security considerations, of course, that cobalt-60 has. And I've seen some questions already in the question answers from our participants who have been asking about the issue of security, safety, and radiation protection in terms of LINAC. Dr. Varney, you'd mentioned in your slide, one of your slides, that there is, yet you seem to be saying that there was more cost or a bigger burden for LINAC in terms of those of radiation protection, safety, and security, and less for cobalt. So I'd like to get your input on that. But I think for all of our participants, all of our panelists, for me, it's always been, my argument has always been, we need access to technology. If we look at the machines, then, and we take that separately, that we need access to technology no matter what the technology is. we need cobalt 60, we need Linux, we need the radiotherapy technology, you know, equipment that can actually deliver the radiotherapy and radiation care that is required in countries. And for some countries, it is much harder to use linear accelerators than cobalt 60. And of course, this is changing because linear accelerators are evolving and developing. And as Hester has said, there's the realization that there is a need for change and there are challenges. And the training that is being delivered is one of the ways of responding to those challenges in terms of the higher level of technical capacity and know-how that one needs to use linear accelerators. Another problem is that we have with cobalt 60, the sources are becoming less available. And I see Joel is nodding, so I take it that you're also having this experience. And I've heard this across the board from so many developing countries who have been saying that, you know, it's not that easy to get cobalt sources anymore. And we know that there are challenges in terms of transportation of these sources for various reasons. There are denials into port of these sources when and there's a lack of a regulatory harmonization between countries, which makes it more difficult for the transportation. So all in all, the sources are becoming more expensive. And then of course we have the entire the need to ensure that they are secure when you're using them, when you're storing them, and then of course the end of life management. So all of that disappears when one works with the LINAC. However, there are these challenges in terms of how accessible or how usable LINACs are in countries that don't have enough electricity, that don't have enough capacity to use them, or just to the upkeep of Linux can be very challenging as well in terms of finding spare parts, etc. So I want to put that to the panel and ask you, and we'll start at Alfredo, and basically just ask you, having heard all of the discussions here with the knowledge that you have, what would you say is the answer at the moment in terms of Linux and cobalt 60s? What would your remarks be in this regard?
Thank you, Ingrid. I think it's a very interesting question, very important and very difficult to answer, as you said, no, because there are many elements that play in trying to answer the question. I put in the chat box our latest publications regarding selection of megavoltage therapy. And here you have, let's say, the technical input that we can, as agency, we can give to this question. As you said, you have the maintenance, spare parts, uptime needs, especially if you have only one machine, dust, electricity supply for cooling, for running the installation. So there are many questions, and no one better than people on the ground to try to understand and to answer those questions. I think choosing the technology is something that has to be an informed decision. Everybody, every player here around the table can give their input, but at the end of the day is the member state, is the country, the Ministry of Health, the Ministry of Finance, who has to put everything together and try to make the right decision. Sources are more and more expensive, are difficult to find, to transport, regulations at the customs. So there are many elements. Spare parts for Linux are expensive and sometimes very difficult to get as well. So it is, I don't have the answer, but I do want people on the ground to understand that this, again, multidimensional, and the most important thing is to take informed decisions. To stress the training of the professionals. So you have to keep a balance between the technology you have in your department and the training you have for your workforce. It has to be aligned. So all those small details plays a very important role in selecting the right technology for your department. And again, the IAEA will be with you, with the countries, with the member states in this process, of course. Thank you. Over.
Thank you, Joel. And if you can also, if you could address that and just shed some light on that slide that you had that comparison.
Yeah, the comparison is from our perspective and reality. But as I mentioned previously, it's not a simple decision to make. As you can see, there are merits and demerits. It's up to each country to consider the points that have been repeated by all the panelists and determine what suits them. But of course, they have to be aware of all the demerits and merits. Ghana, for instance, is in the process of acquiring five LMICs, and I'm sure that will improve our radiotherapy utilization. The point made by Hester previously regarding the training, we sent a team to South Africa, and therefore the transition from using the LMICs was very smooth. Indeed, we were doing 3D with the Korle. So we were already drawing volumes and all before we got the LMICs. So the transition.
I'm so sorry, I'm struggling to hear you again. Can you sit?
I said that we were drawing volumes and treating on the cobalt prior to acquiring the LMICs. So the transition was very smooth. So in concluding on the question, there are demerits and merits. Every country has to determine what suits them, but that must be done from an informed position. You have to be aware of all the facts and then make a decision that suits you, your context.
Thank you, Joel. And just to ask you a follow-up question. So if you look at, one of your challenges, as you said, was to actually get this more treatment possibilities out to the rest of the country, because there is not a broad enough spread within the country, which I think is a problem with the majority of countries in Africa. If you had all the money in the world at the moment and you could choose, what would be the best use? I mean, how would Linux work in those remote areas as well as the Cobalt 60, or how would that work, basically?
Yeah, luckily I'm not the one to decide. Mine is to present all the facts to government, and government will determine what is supposed to do, but to be aware of the discussion, the merits and demerits.
Yeah, so it depends on the environment and the decisions that the governments take, and then they have the support, of course, of the IAEA, as we've said. Before I go to Hester, I just want to say that we've had in the chat, you see, this is the problem when I have to go between chat and Q&A. So in the chat, we've had Emil Hensler from Electa has popped into the chat there to say that, of course, there are Electa training opportunities as well. And one can access those opportunities, Electa Care, Learning Educational Resources, Electa. So if one goes onto their website, www.electa.com, .com and then best regards. So it's www.electra.com. And the Electra Foundation sets its sights on improving cancer care access in underserved markets, bringing hope to people with cancer. So I just need to say at this point as well that we're not promoting Varian above Electra, and these are the two big providers of Linacs. But we have had this opportunity to discuss with Hester, who has been working originally at the South Africa's big hospital, Radiotherapy in Cape Town, who made the transition from Cobalt to Linacs, and then has been providing all of this training. So we totally recognize that there is training and support delivered, of course, from Electra side as well as Varian. Hester, do you have any contribution in terms of the choice between Cobalt 60 and Linacs, and especially from your point of view in having been in a hospital that has made this transition? Do you have any words of wisdom?
So when I was at Radiotherapy Hospital, when I arrived, there were still 2 functional Cobalt units in the department and 1.5 linear accelerators. One was being kept alive with crocodile clips, which is never a really good idea. And the decision had to be taken how to take the department forward. And at the start of the project, we actually utilized empty bunkers and added linear accelerators, but kept the Cobalt units alive. And then over time, the department started struggling with source exchanges. It is a complicated process. There was also a project collaboration between the South African government and the IAEA to secure sources in the country. We were part of that project where they identified the sites that appeared to be at risk and increased the security. It was a collaboration with Sandia Laboratories, as I said, South Africa. And they started encouraging us to reconsider options, which is then what we did. We went back to the bunkers and we saw what linear accelerators would fit. We did cost estimates of the Cobalt units, and the decision was taken over the next 5 years to phase out the Cobalts and then replace them first with Uniques and then with Halcyon. And the Unique and the Halcyon was a simple choice because of a fit into the bunker. So my recommendation to people is this: if you're in that situation, get the information. Look at what you have, but you have to look broadly. You have to look at your infrastructure. You have to look at your service technical support, your electricity stability, whether you're living in a humid environment. All of those things can potentially push you in a certain direction in terms of what will work better. But even within the world of linear accelerators, there are different types of linear accelerators. You know, there is the Halcyon, which is built to be a much lower power usage Linac combined, but you still need access to your technician. So when we do procurement training with people, we take the teams and we put them in front of a whiteboard, literally. And when they're in the department, we have a table full of little cutouts of Linacs. And I have to say, we include Electra and Varian Linacs. The whole table is stacked with them with magnets. And we say, build your department. Show me what you see in your mind as your department. And once they've done that, we start asking them questions. Did you think of this? How are you going to get this to talk? Do you have stable this? You know, will your shielding work, etc. And the minute people start thinking about it, they realize, oh, okay, I'm leaning towards something specifically. I'm in an environment where I have stable technicians available. I lean towards my linear accelerator because it did decrease the cost associated with the security of the Cobalt sources. When I was in charge of the department, I had days, and I say this openly, when I thought to myself, that day that the fire breaks out and fire department has to run into a building where there are Cobalt sources, you know, how am I going to deal with that scenario? Because people will be at risk going into that environment. You have to plan for it. Whereas the minute the sources were removed, that element was removed and we had to deal with other things. So my advice to people is get the information, There's a lot of information out there from the manufacturers, the vendors, the IAEA. All of them have the documents where you can do your research. And then place yourself in your environment, not where you would like to be, but where you really are, and ask yourself what will work best. That's my advice.
That's fantastic. Just a follow-up question is, the training that you're giving, is it specifically for Varian Linux, or does it cover any Linux?
We discuss Linux in general, quality assurance in general, but the training platform, the planning system that we have access to is Eclipse. So it automatically goes towards Eclipse. But the principles of contouring, for example, it doesn't matter on which system you contour, you learn. So we have teams coming in this year that are non-Varian teams. They acknowledge that they will first have to find the buttons, and we will teach them that. But after that, the ICRU principles that we do use all the time in radiotherapy, they can take that back to their own departments and use it on whatever system they had. So we have actually had non-Varian teams from Nigeria one, I think Zambia one. We've got a team now coming from South Africa from a non-Varian site, and they are attending the training as well.
That's great. Thank you so much, Hester. Nina, I'm just going to pause to get to you on this answer, this question, because we're starting to, we're running into our last 10 minutes, and I just want to bring in some other questions. We have one from Ambassador Sapag, the ambassador of Chile, and here in Vienna, and she's saying, are there any statistics on drain brain in Africa and impact of lack of oncologists and radiologists? Any good retention practices in place? So there's a couple of questions in that one. And then we have a question from Anita Nielsen. If taking the patient's perspective, I assume that the first objective is to get treatment, whether it is 100% or at a somewhat lesser level. It does not matter that much if it's alternative or no treatment at all. It does not matter that much if the alternative is no treatment at all. Should we not try to factor that in as well and recognize that there is time for both phase in and for phase out, not abrupt changes? We should be able to deal with difficulties, difficult issues with cobalt sources as well. And then we have one from Rahman Gaisi, and he's referring to this issue of radiological terrorism and enhancing access to radiological services. And I think we have very much addressed that in terms of the discussion of the linear accelerators being that they're more secure, that they don't have the security risks, but also, of course, that we have the IAEA that provides support to countries to ensure that there is protection of these sources in their use and their transport. And there is the all of the considerations that countries take into account, and when using these sources to protect them from being used, stolen and used for terrorist purposes potentially. So I'm going to, before we get to Mesahud's question, I'm going to just go back to our panel. And I think ask Nina if you want to address some of these questions at the same time, and perhaps, I don't know if you know, you go for it, and then I will redirect the questions to some of our other panelists.
So the question from Belen Sapag about brain drain. So I don't have vetted answers or statistics for him, but I did just go to the website, the Mo Ibrahim Foundation, and I just put the link in there. It's a 2018 article on brain drain and the bane of it in the Africas. And I did look at that for a moment, and it does focus right in with healthcare professionals being one of the critical or problem that they're looking at most. So I did see some interesting statistics, and I will follow up with that information. I think it's very pertinent to the discussion, especially in regards to the number of radiation oncologists and related staff or personnel that are going to be needed over the next 8 years, is what those statistics were that from that study. In relation to Anita Nielsen's comment, I think that the example that Hester just gave also, you need to give time to make that transition from the cobalt machine to the linear accelerators. There are options and still techniques that can be improved and supported in the use of the cobalt machines. We're working with an institution right now that has a cobalt machine, but that's looking to put a linear accelerator in the next several years. And the work that we're doing with them for that and their brachytherapy is enabling them to be prepared to adopt the future technologies as they come in and as they evolve. I mean, as I think it was Hester who said, the technology is evolving so quickly that it's very difficult to keep up with it, and to ensure that the training and I use this in a very positive sense, but the hand holding that many of the institutions and people that we work with, having a mentor and someone on the ground that can be there during actual treatment delivery is critical. The book learning and the video conferencing is important and needed and necessary, but it's the next step of having people on the ground for committed time periods after building trusted relationships that are imperative to help, support and work hand in hand with these institutions to continue down the trajectory of delivering the best care.
I think that's very well said. Masood Samai has come in with just reminding us that when talking about radiotherapy technology, we must concentrate on suitability, affordability, and sustainability, and not whether LMICs are better than cobalts, as well as life cycle costs of technologies normalized by the number of patients treated or fractions delivered. There must be an emphasis on developing LMICs that have the above three characteristics. So he'd be grateful to hear what is the IAEA doing to promote the improvements needed in LMICs to make them suitable for challenging locations, as well as affordable and sustainable. And when thousands of patients are dying unnecessarily in Africa and elsewhere, one must focus on delivering the right technologies. This requires a global concerted effort with the IAEA, which the IAEA might lead based on its extensive experience in multiple relevant programs. Alfredo, can I hand that question to you? And then I think, Nina, if you would like to come in shortly after that, just to talk a bit about the changes. I know that you've been also working in that direction with this Project Stella in terms of making, adapting technology and looking at the adaptation of technology for developing country conditions. Sorry, Alfredo.
Thank you, Ingrid. Thank you very much. Yeah, I think I agree with Masood, and this is what we said in the presentation. Resources are limited, so you have to choose. And there is an opportunity cost in investing in a LINAC over investing in a cobalt. Resources are limited. There are no unlimited money and unlimited resources to invest. So there is an opportunity cost, and this is a responsibility of the countries, of the member states, and the governments. We do support both technologies, and we do help countries in implementing technologies. By the way, safety and security of the sources is a responsibility of the country, and the regulatory authority has to be in place exactly for this reason. And the IAEA helps member states to develop the infrastructure to enhance safety and security of any type of nuclear installation. We are very good at transferring technology. We are not a research organization, but I know that the CERN is working on one of these technologies to make LINACs having a smaller footprint and being able to be implemented widely. We have been working with CERN. We don't have all the details about the project. Maybe Nina can expand a little bit on it. Manjit is also on the call. And but we are ready to implement and to transfer the technology if this technology one day is mature enough to be implemented. Nina, over to you.
Yeah, Nina.
Sure. Thank you, Alfredo. And thank you, Masood, for the question. It's very relevant. So ICEC has been working with CERN and STFC for a number of years to identify the challenges that those on the ground are facing using these linear accelerators. One example, one of those resources that is listed is this African survey that was headed by Manjit Dosanjh, who's on the call. This is where we brought 28 countries in Africa that actually have LINACs together to answer a robust questionnaire identifying the faults and challenges related to the linear accelerators in these challenging environments, not only in Africa, but that are also found, many of these challenges that we're talking about are found globally. So we continue to work forward on this project. It's been a difficult but challenging to understand the issues. And we're taking the information that we have learned to understand and figure out if we can actually develop a machine, that the project would develop, that could be utilized and for the environments to address many of the challenges that we've heard today: service and maintenance problems, ease of operability. How do we address the number of work or reduce the number of workforce that are required to run a LINAC? And then also to manage these breakdowns in a very effective way. So you can come to IC's website, or if somebody can give me a call or drop me an email, and we can give them more information on it.
Thank you so much. I think that's one of the big challenges that what we always, often hear, exactly this issue of having technology that is appropriate for developing country conditions. And of course, as you've all mentioned, technology is changing and evolving all the time. Sorry, Nina, you wanted to say?
Yeah, I do. I just want to make sure that people understand the scope of the problem. So right now, we need 5,000 linear accelerators just in Africa over the next 10 to 15 years. If we installed one linear accelerator a week, it would take 100 years to resolve this issue. So the magnitude of the problem is enormous. And so we have to come up with innovative ideas and solutions to fix this.
I agree. And I think the point also Masood is making is, and Masood and many others, is that we need technology as such, whether it is, and all of the whole cancer care package, of course, but it's not just linear accelerators. If there needs to be cobalt teletherapy units until such time as we are able to have linear accelerators that can work properly in any kind of condition, and have the capacity to be able to, and that there is enough capacity to be able to manage and use these linear accelerators to their best possible potential. And this is what is so encouraging from what Hester has been telling us as well, I think, and the work that you've been doing and the work the agency does to support training, etc., to get this technology, to get as much support as possible in terms of being able to use the technology close the gap, basically close the gap. So I think just to sum up, because we've gotten to the end of our time and it's been really fascinating and there are many other questions, but I think if we could, I'm going to start with you, Joel, because you now haven't had a chance to speak yet. Then I'm going to go to Hester, then to Alfredo, and then to Nina for some final comments. Joel.
Yeah. So the slide that I showed on utilization, radiotherapy utilization, sort of emphasizes the fact that there are other issues other than putting radiation therapy machines in the country. So it must be considered in context. In regard to brain drain, there's nothing that you can do about it. It's a free world, but one way of addressing the problem is to ensure that you have good training programs so that there's a constant supply of workforce with appropriate training. And I have had opportunity. I was trained in South Africa, Johannesburg. That's why I did my residency. At the time, we had Cobalt, and I have done a fellowship in Princess Margaret Hospital, Toronto. So I've seen the wide range of services. So I still come back to what we've been discussing and emphasized by Alfredo that it depends on the country context. And so be prepared to make a decision that suits your context in terms of balance based on knowledge of what the machine can do. Thank you.
Thank you so much, Joel. Hester?
I think there's only one thing I would say is that if we were to give up because of the enormity of what we're facing, then nothing will happen. But if we keep trying, I saw a thing in the FAMPO newsletter just yesterday, and I think it was something like 1 to the power of 10 is 1, but 1.01 to the power of 10 is suddenly no longer 1. The small changes have impact if you keep making them. And I think that there are many people in the low and middle income countries with a desire to create this change. And if all of them work together with the help of the high income countries, we are going forward, and just don't give up. That's all.
Thank you. Yes, I think the relationships and us working together as a global community is really important, and one of the key things I'm drawing from this discussion that we're having. What did I say next, Alfredo?
Thank you, Ingrid. Yeah, an optimistic message as well. Yeah, as Hester said, we need better policies for cancer care. There are many agencies, institutions, professional societies and bodies that can inform to create these better policies. I think this is very important. Also to engage the development community. They will be more and more engaged if they see that there is a cohesive, a comprehensive message in what we do. And yeah, and agencies like the IAEA is here to help member states in their projects to give better care for the populations. Thank you.
Thank you, and I like the mention of how one provides a united front in terms of the needs that there are and the policy the policy leadership that one needs. Because I've been speaking to many people in the development sphere, and especially in the EU development sphere, about how does one get more money and funding from your development organizations, and how do you get them to recognize the need to include radiotherapy into the cancer continuum and to support the agency in doing that. And their message is member states aren't asking for that. Countries aren't asking for that. In Africa, countries aren't identifying that as a priority. So I think that is another part of the equation, is really that we have to make that message very clear that there are many priorities in Africa, and this is one of the priorities. And it needs there are people who are millions of people needlessly dying. And we need to address this as a global community. Nina.
So my closing response would be, or comment would be, we have to remember that people treat cancer. and the machines just enable us to do that. But the radiation therapy and access to radiation therapy is an element, essential element of comprehensive cancer care. So to what you were saying is, if you don't have radiation therapy, you don't have a program that has a comprehensive approach to cancer care. And then what's nice about this call is that all four of us speakers are all really driving to the same thing, and that is to improve access. And we know that you can go to the IAEA and get wonderful resources to help. The work that Joel is doing is just wonderful. You know, we've worked with him. We see the efforts that he's doing, helping to improve cancer care in other countries. And you as well, Hester, and the work that Varian's doing with these very important training programs, offering this technical support. But it goes to a quote that we often go back to, and it's, we're all faced with a series of great opportunities that are brilliantly disguised as impossible situations. And that's what it appears as though we're in, but collectively, I think we can solve it.
Fantastic. Just the right quote to end this discussion on. Thank you so much. Thank you for all of your efforts to close the care gap, because that is indeed what you are doing on a daily basis, and for being so inspiring. And I hope we can meet in person in future. And please, when you come to Vienna, everyone on the call as well, please drop in at the VCDNP. Let's meet, let's talk, because there is much to be done, and we would like to do our part as well in this regard. So have a fantastic weekend, and thank you so much. This was a really inspiring discussion. Thank you.
Thank you.
Thank you.